we have a big problem here, and we really need to understand and to change our habits, because otherwise we will have more viruses, which will maybe also follow into pandemic. Next is the transmission of SARS-CoV-2. So we know that, of course, we have an airborne transmission and an atomization. And the problem is that it is it's also through aerosols, and this is why the virus can also follow really, really large distances. We didn't know that at the beginning, but then when we realized that if, for example, you are in one room with several people working, for example, in an office, it is absolutely possible that the virus is then following a long distance of several meters, and then you can get infected. Another problem also of the contagiousness of SARS-CoV-2 is also when you are contagious. So there has been a very nice paper which has been published last year, and they analyzed different cases of SARS-CoV-2 and then try to understand when the virus load and the contagiousness of the SARS-CoV-2 was the highest. And they could observe that before the symptoms start, before symptom onset, you already have a high peak of contagiousness and a high virus load. This means that it's really difficult to control the pandemic, because you are already spreading a lot of virus and you are not in, you don't have symptoms yet. So what are the primary symptoms of COVID-19? I know you know all that, but I just want to do it again. So we have a congestion or runny nose, and we have also a loss of taste or smell, which is really, really characteristic. When you have a person who says, I have no loss of taste, then you can be pretty much sure that this person will have COVID. Headache, cough, shortness of breath with difficulty of breathing. There, the infection and the disease is already progressing. You can have also nausea or vomiting or diarrhea. So if you remember at the beginning, I was mentioning that the ACE2 receptor is highly expressed also in the gut and the intestinal tract. This is why it explains here the symptoms. Fatigue, muscles, body aches, fever. This is something which is characteristic of viral diseases. Also, if you find RSV or influenza, you will also have this kind of symptoms. And the symptoms appear in the middle between 2 and 14 days after the exposure of the virus. And this is why also, if you had a contact with a person, you need to be during these days very, very careful and conscious if you develop symptoms. The main problem here is the acute respiratory distress syndrome. And you can see it here. This is one of the first pictures, also an X-ray of the chest. And it's really, really impressive. This is one person within 1 day, and you see the changes of the lung here. I mean, before the start of the pandemic, it was really, really rare to see such pictures, and it's really, really impressive. And if you look also at the lung, when people are dead, then you see here the lung, macroscopic and also microscopic, and you can really see that you have a damage, a diffuse damage of the alveolars, and which are everywhere in the lung. And you can absolutely imagine, if you see this picture when this person dies, how the lung looks like. And what we have here also, and this is really characteristic also for the COVID disease, that we have some thrombi and coagulopathy, which is here observed also in the lung. Besides the pulmonary manifestations, we have also extrapulmonary manifestations. And you can have a whole picture which is completely different also. So you can have dermatologic problems, which is a problem of the systemic disease, neurologic problems, cardiac problems, also but hyperglycemia or diabetic problems, gastrointestinal problems, I just mentioned it before, then the coagulopathy with thromboembolism, the hepatic problems, but also the renal problem. So it shows you that it is first a pulmonary problem of the lung, but then the disease is just it's in the whole body, and then you will have a lot of problems. So what is the exact course of the infection? And this is also important to understand because it's important also for the treatment of the patients depending on the stage of the disease. Here you see always the virus load, okay, it's in green here, and at the beginning, so we have, first of all, a pre-symptomatic phase. The viral is increasing here in the body. Then you have a peak of the virus with the replication, and at the beginning, you have a mild to moderate illness. This is what we all know. In this phase, you have the antibody response here in blue, which is starting. And this is really decisive here, what happens here, because most of the patients are getting better, but if not, then you have then hospitalization, shortness of breath, you have a severe illness, which then can develop also in critical illness. And it's important to understand that during this phase here, severe and critical illness, you don't have a high viral replication. You cannot see it here. We have here other phenomena which are causing the disease. And we have a high immune activation. And the high immune activation, this is what why you are getting very ill. And this is important to understand that in the first phase of the virus, of the disease, you have a high viral replication here. And then in the second phase, you have a control virus, but you have very high immune activation, which is pathogenomic for the SARS-CoV-2 infection during the critical and severe illness. So you can imagine that the immune response is really important also, and it could be also a risk factor for susceptibility, but also for severe COVID-19 disease. And we know that older persons have an impaired B and T cell response compared to younger persons, but also the impaired B cell response leads to a reduced ability to develop neutralizing antibody, which are really, really important to fight the disease. And so the impaired B cell response, you can imagine, for example, if you have a cancer and you have chemotherapy, then you have a impaired B cell response. But also the T cell response is really, really important. And we know that it's important to fight also the infections. And for example, if you have HIV patients with less T cell response, we know also for them that they have a bad course of the disease. So we have older persons, but also younger persons with a dysregulated B and T cell immune response, which are really have high risk to develop a severe COVID disease. Importantly also, that we have a difference between men and women. And we know that this was really interesting that during the severe and acute COVID disease, that we have more men compared to women. So you have here the age at the critical care admissions, and you have here in blue the percentage of man population, and you can see that men are more affected by a severe COVID-19 disease compared to women. This is also something we observe also in other infectious diseases, that we have a sex-related difference between the outcome of the disease. Besides the sex, we have, of course, other factors like the racial or the ethnic minorities which are influencing also the outcome of the disease. So, for example, the living and work conditions are really, really important. If you live with a lot of people in a house, or you have limited access to healthy food, of course, the course of the disease will be not so good. And also the access to care and to health care is really, really important. And we know this is why we are doing also this meeting here yesterday and today, how important it is and how we have to change it. So if we want to manage the COVID disease, then you have to understand in which phase of the disease the patient is. And this is what I mentioned before. So here we have the different phases, okay? The asymptomatic, mild, moderate to critical illness. And most of the patients here have a mild to moderate illness. And during this phase here, at the beginning, we have a viral replication, as I showed before. And after this, we have a high inflammation and immune activations. And this is why the treatment options we have are really different. So at the beginning here, we can use antiviral substances here during the viral application. And we can also use maybe antibodies. But then when the disease is just continuing, then the goal should be to decrease the inflammation, and the antivirals wouldn't work in this phase. And this is what I want to show you, what treatment options we have in detail. So the first medication we have, the first treatment we had was remdesivir, which has been, this paper has been published last year. And so we can use it also, we can use the remdesivir, and it has been approved for hospitalized patients, but really at the beginning of the disease. We have to be very critical about these data because you have a very short period where you can give it, and it's only for hospitalized patients. And it's really difficult, for example, to give it to patients with mild or moderate disease, which would be very important in this phase. It's really important to give it in this phase, but it's difficult to give the remdesivir because it is intravenously. The next option, I think, which is really, really interesting, which is not on the market yet, is the molnupiravir from Merck MSD. And this is a tablet, and it's you can give it in the tablet. So it's an oral application every 12 hours for 5 days. And it blocks replication cycle of SARS-CoV-2. And it also has an effectivity also against influenza and all other coronaviruses. So a very broad activity against different viruses. And the data so far are really, really good. And if everything works well, I hope that at the beginning of the next year, we will have another treatment options for patients at the beginning of the disease, and which, for example, a house doctor could also prescribe. The next treatment option is the dexamethasone. And this is a corticosteroid, and this medication is reducing the inflammation. So this treatment option is very important, and you should only give it during the critical phase of severe or critical phase of the disease, and not at the beginning. Because if you give it at the beginning of the disease, then you could also induce a higher virus replication. So only give it after 7 to 10 days after the beginning of the symptoms, not right away. And there had been a randomized trial with different groups. And the primary endpoint was the mortality at day 28. This was a really, really high, a big study with a lot of patients included. And you can see here the results. And you can see that the patient who received the dexamethasone, they have a much better outcome compared to the patients who only had the usual care. Okay, and you can see it here, more pronounced here. You have decreased mortality, and especially in the patients with the mechanical ventilation. Next thing is the neutralizing antibodies. So neutralizing antibodies are very important, and we call it the passive immunization. We have multiple ways to give the neutralizing antibodies. We have the monoclonal antibodies, we have the hyperimmune immunoglobulins, and we have also the convalescent plasma. And I just want to show you some examples. So we start with the convalescent plasma of patients. So you have to imagine that you had a patient who had the COVID disease and is now completely recovered. So this person has neutralizing antibody in this blood. And so this donor then is undergoing an apheresis, and then we are getting convalescent plasma. And this convalescent plasma is then donated to patients with an active COVID disease. And so we have here the neutralizing antibodies from this recovered person to the critically and actively ill person. And so this was a very good idea. And I have to say here in Cologne also, we also wanted to do it. And we had a lot of recovered patients who come and who got the apheresis. But unfortunately, the study showed that there is no clinical benefit for this treatment option. And so this is not an option to give convalescent plasma to treat patients with COVID-19. This is what we know now. The second thing is the monoclonal antibodies. And this is something which is, I think, really, really interesting also for other disease if you just think about the future. And there are different kinds of antibodies here, the bamlanivimab, casirivimab, and imdevimab. These are antibodies which are really, really well working. And so we have an approval here for casirivimab and imdevimab. You have to administer it intravenously, and you give it about during 30 to 60 minutes. And what is really, really important also here, you have it to give it very early in the disease. So during the 7 first to 10 days after beginning of the symptoms, then you could give the antibodies. If you give it later, then it will not work. And what is also very important is that you can give it also to pregnant and lactating women. We had here several cases also where it was very important that the pregnant women will control their disease. So if I just summarize, we don't have a lot of treatment options so far. There have been a lot of different studies, a lot of really, I have to say, not really plausible treatment options. But what we have so far, that we have the remdesivir, molnupiravir, which I think as antiviral substances, as tablet, is really, really something I hope we will get in a few months. We have the dexamethasone, which is only important to give during the late phase of the infection. And we have the neutralizing antibodies. This is what we have so far. So it's really important to get vaccinated, but you know that. Besides the acute phase of the COVID disease, we have also the long COVID disease, or the post-COVID disease, which is also, I think, very, very important. And if you look at the timeline of COVID, I think you have to look at the whole disease. And the whole disease means that you have the beginning here, where you have the viral replication, then you have the acute phase of the disease, which I just described during the last minute. And then after that, you have the long COVID syndromes. And this is something also, which is also very, very important, and what we don't understand yet, but I think which is really, really relevant. We know that the long COVID syndrome is something which is affecting different organs. So we have the lung, we have the heart, we have also the brain concentration, the brain fog. We have neuropathy, we have kidney diseases, but also diarrhea. So a complete different organs are here affected. But it's important to differentiate between the post-intensive care syndrome, what is a complication after intensive care treatment, for example, the critical illness polyneuropathy, which we know also from other intensive care treatments and other diseases. We have the post-viral chronic fatigue. This is a fatigue after viral illness. It is a complex condition which is not fully understood. And we have also the post-traumatic stress disorder, which is also important. It is a disorder which is caused by a very stressful event. And with all this discussion, I think it's important to make the differentiation of the different syndromes we have so far. Moreover, if you look at the literature, we don't know the percentage of the long COVID syndrome in different patient groups. And this is why the studies are really, really different. It starts that you have different patient groups. You have hospitalized patients, you have non-hospitalized patients. Also, the time when the symptoms are measured are completely different in the studies. Also, the recruitment and the symptoms are completely different, and the number of the participants are also very different. So you see here that there are a lot of things which are not understood, and this is why it makes it so difficult. Here in Cologne, I just wanted to show you some data. We had a cohort of recovered patients. We wanted, we called them for the plasmapheresis because we wanted to get convalescent plasma. And so the patient came every 3 months to visit us. And we observed that after 7 months, there are several patients who still have symptoms after mild acute disease. And what we could observe here that more females are affected by long COVID. So this is different compared to the active disease where more men are affected. And most of the patients still have anosmia after 7 months, shortness of breath, and fatigue. And we could identify different risk factors or predictors of long COVID, for example, diarrhea during the acute phase, the anosmia, and also low IgG, immune globulins, during the acute phase. And especially the low IgGs during the acute phase are predictive of long COVID syndrome. So this is what I wanted to give you. I wanted to give you a little overview. Let me stop it. I wanted to give you an overview about the COVID disease, and I think I could show you that we have different phases of the disease, the acute illness, but also the post-COVID, the long COVID syndrome, which is really, really important. And this is also, if you have all the discussion, this is something we shouldn't forget. And I'm happy to take questions.
Thank you so much, Clara. I'm glad that you corrected yourself. You said you wanted to give a little overview, and then you said, I gave you an overview. Yeah, it's frankly, again, it shows the importance to understand and to, at least in all the frequently nervous and emotional discussions, knowing that we do not know everything, but to clear the ground and say what is really known, what did we already observe, and what can we say now with some certainty to help to reduce the irrationalities in some therapeutic approaches. And I think the different phases that now seem to be more clear are very important. So thank you. And I know Lisa, who is around, has collected already some questions from the audience. Lisa, would you take over and bring up the first question from the audience?
Yes, sure. Good morning, everyone, from my side as well. The first two questions are related to the immune activity and the disease severity. The first one, I didn't quite understand the connection between a high immune response and the severe illness while the virus load is low. So why is the high immune response so harmful? And the question from Lena is also relating or going in the same direction, is if a high immune activation after some days of infection could lead to a severe COVID-19 course, could then the high immune activity caused by vaccination also lead to a severe COVID-19 course in the case of infection? So these are the first two, and I'll just give you time to answer.
Yeah, so thank you very much. This is really important, and this is something which is not really easy to understand. We know this also from the influenza, for example, but also from the HIV infection. So you have to imagine always when you have, for example, a viral disease, you have an immune response which is starting. Okay, and this is something really important to control the infection. And then there are factors where you have a too high immune activation, okay? And if the immune activation is too high, on one hand, it's good because you fight the viral replication. This is very good, but it's like a side effect of this immune activation, and you destroy your own body. For example, if you, another example I would try to mention. So if you have a car and you drive with a gear shift, I don't know, in the 5th or 6th, okay, you drive very, very high. Okay, so you have, for example, you have a high immune response. After a certain period, it's just too much and you destroy your own body. You destroy the vessels, the kidney, you destroy everything. And this is something we know also from other diseases, that on one hand you have the control of the virus. This is the immune response. But the side effects are that other cells are destroyed, and this is harmful. Okay, and this is nothing new also from the COVID disease, but this is what we observe very pronouncedly here. Okay, this is the first question. Second question is if we can observe an high immune response after vaccination. Here, this is something different because we don't have a virus replication here in immune vaccination. You only have the spike protein. And of course, you are inducing an immune reaction, an immune activity. And in very, very rare cases, then the immune response is too high. And for example, you could develop a Guillain-Barré syndrome, for example, but it's very, very rare. But it's not the same pathophysiology. It's something completely different. So the vaccination will not induce a high immune activation, which you are not able to control.
Okay, thank you very much. The next 2 questions are from Luisa and Astrid regarding the antiviral treatment. The first one is, do we know if there are negative consequences if we start antiviral medication, even though we don't know yet if the patient will have a severe process of COVID? Because usually starting early is better, so would it be recommended to give antiviral medication to anyone who's tested positive, despite, of course, potentially hard process to achieve this in practical aspects? And Astrid would like to know, would you give molnupiravir only to those with severe symptoms or to everyone?
Yeah, so this is really interesting question, also strategic question. So for now, we have only the remdesivir, and the remdesivir is really difficult to give, okay, because it's not a tablet, you have to give it intravenously. So this is something you can't give to everyone. It's absolutely impossible. And so the results of the studies are not so convincing, I have to say, that I would suggest to give the remdesivir very early during the disease. In contrast, the other antiviral substance, the molnupiravir, it's really difficult. I hope they will find another name. This is something I think very interesting. And this is something also which should be given very early in the disease because it's a short treatment and it's very, very well tolerated and the side effects are very low. So if possible, I hope it's not going to be too expensive that everybody can get it. This tablet should be given to I mean, if possible to everyone, but first of all to older people or to people with, for example, immune problems or something like this, or, you know, patients with after transplantation or with the cancer and chemotherapy. So these would be the first persons who should get this molnupiravir. And after this, maybe also other patients, other persons.
Okay, I have another set of questions that just came in. It was from Enoch. Question 1, what can be your comment on azithromycin, a commonly used drug in sub-Saharan Africa against COVID-19? Question number 2, vaccine trials take years to develop. SARS-CoV-19 vaccine developed very rapidly. Long-term effects are a worry, especially lack of approved pharmacovigilance plans of the vaccine. And the third question is regarding the diagnostic test specificity. How good is it, especially in the midst of the variant forms and the prevalences?
Okay, so thank you very much for the question. I think the third question, this will be the topic also of the next talk, so I will not respond to that question. Okay, maybe you can get it to the next talk and to the other questions. So, for example, the azithromycin or also other antibiotics, there have been a lot of different studies, and I can say to you that they are not working. I think the past was over the ivermectin, or there have been also HIV medications. They have been all studied in different studies, and it's important to do it also, to test it in studies, but they didn't work. And the only drugs we have so far, the antiviral drugs we have so far, is the remdesivir and hopefully the molnupiravir. Okay, but all the other drugs right now, the study didn't show that they are working, and they didn't show any effect. To the other question also, the development of the vaccines. I know this is always the argument, the studies, the time course is very short. How can you be sure that there are no side effects and long-term effects? I can just assure you that the studies, I mean, I have also done here a study here with about 1,000 patients, and we had 40 people who were only doing this study, and we were just controlled 2 or 3 times a week of all the official agencies and everything. So, and all the studies have been done very carefully. And I can say that all the researchers and all the clinical staff, they were just working on that. And this is why it was possible to do all these studies. And they are controls also. For example, the studies here, I was leading here in Cologne, for example, it was CureVac. And so the results were not good enough, and it's not on the market right now. So it doesn't mean that if you do a clinical study that a vaccine is right on the market and will be approved. And there are so many vaccine studies which have not been approved because all the agencies are controlling the vaccine, the efficacy, the side effects, and everything. So with the treatments and the vaccine technology we have right now, we are lucky that we have vaccines that are working so well. And with the technology we are using right now, I don't expect long-term side effects, because this is completely new technique, and without, how can I say, without adjuvants we had in other previous vaccines. So I have to say that the concerns people have about the very fast development of the vaccines, I absolutely can share it, because I think it's really, really safe, and the results right now are absolutely excellent, and we are lucky to have these vaccines and this new technology.
Yeah, thank you so much. We have another 2 questions, but I think we're over time limits. So over to you, Florian. First.
Yeah, it's a pity. It's a packed program and very pertinent questions that are still open. But maybe we can at least keep them, and we'll see whether we can discuss with our next speaker, or yeah. Anyway, it's a tough time, and I would just want to say thank you again to Clara, and the way that the questions pop up in an audience that is very much into it shows you how important it is. And I think we need to keep on raising the voice of rationality in this, and not diminishing our emotional concerns, but to see what is really out there, what can we do to overcome definitely the anxiety. And I also have to say, I liked the way how you split up the ideas about the long COVID, and anxiety is not any worse as a problem resulting from COVID than a viral effect. We have to take it equally serious, but we also have to say how best can all these problems be addressed. So thanks again, and I hope Claudia Denkinger has joined us so that we then would carry on to our next speaker, and thank you.
Yes, hello, good morning, Florian.
Good morning. Yeah, it's my pleasure now to welcome and introduce our next speaker. As you have noticed, Clara hasn't spoken about the diagnostics of COVID, and because we have another expert in this field. Claudia, she is a medical doctor, but she is also somebody who has this spectrum from clinical care to epidemiology and global health, and also from patient care to more lab-based work and developing of diagnostics. So that can be seen in her career path. Now she is the director of the Clinic for Tropical Medicine at the University Hospital in Heidelberg. But before that, she was with FIND, this cooperative institution for new diagnostics in Geneva. And that also paved the way that she was very instrumental in testing new rapid diagnostics for COVID, which play a very important role. So we have already taken some time. I won't take more of your time. We are excited to listen to you, Claudia.
Yeah, thank you, Florian. Thank you very much for inviting me to speak here, and hello to everybody all around the world. Glad to have you here and look forward to the discussion after the presentation. First, a question: do you see the presenter mode, or do you see the slide deck? Can anyone tell me? Okay, I assume you see the slide deck in full and not the presenter mode. Good. All right. As Florian already highlighted, I'll be talking about testing, and what I want to convey to you a little bit through the next 45 minutes is following these questions. I hope at the end of this talk, you can understand what are good tests, what is the best test for SARS-CoV-2, how it differs on the use case, what you're using it for diagnosis, for screening programs. I hope you will get a feeling of how good rapid antigen tests can be done by non-skilled workers. You can understand what antibody tests can and cannot tell you, what tests are the most important for public health measures. I also want to tell you a little bit about access to testing and how COVID has affected TB as an example disease or other diseases, and what does that mean for us in the long term. I'll start with a quick transparency declaration. So I have received research grants from various public donors and NGOs for SARS-CoV-2 antigen testing. I have not received any industry funding. I'm a consultant to the Gates Foundation on tuberculosis diagnostics and also to the WHO, both without funding. And I have a partnership contract with FIND, the Global Alliance for Diagnostics, which Florian mentioned was also my prior employer before I joined the University Hospital here in Heidelberg. So, diagnostics. Why are diagnostics so important? Because without diagnosis, medicine is blind. We don't know what we are treating and how we should be treating it. So diagnostics really is the first step in the care cascade, and is thus critical for individual as well as population health. And this was obviously recognized very early. This dates back to March 2020. So at the beginning of the pandemic, I actually forget whether at that point the pandemic was already declared. Tedros said test, 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 most important to enable isolation, contact tracing, and that thus is the backbone of the global response. All right, so how can we test? In order to understand this, we first need to understand the virus, and you already heard a lot about the virus and how it causes disease from Clara. So some of this might be redundant, but I wanted to portray you this slide as I think it very nicely depicts the virus kinetics. So what the virus is doing in our bodies, how it's replicating. And this is the day 0 here on the x-axis, which is the day of symptom onset. And you can see that this curve here, which is the viral load, the higher it is, the more virus you have in you, is already quite high at the time when you first develop symptoms. So you have this asymptomatic phase or pre-symptomatic phase where you can transmit virus because you already have a lot in your upper respiratory tract, but you don't even know yet that you have the disease. And then the viral load goes up further. And you can see down here, like here is approximately day 4, day 5. In all of our studies, we have seen that this is about when patients come to the doctor or to testing in general, because this is when they think, okay, this cold, this headache, this fever might be something more than just my common cold, and they present. So by then, you can imagine a lot of the transmission has happened already. And we know that about 50% of transmission is actually pre-symptomatic, asymptomatic, or minimally symptomatic. Minimally symptomatic is if you have kids and have that sore throat that you have like every 3 or 4 weeks, that is minimally symptomatic, or a little bit of a headache. It's something that especially people with children get a lot. So it's this transmission that's happening, making up 50% of our of the transmission overall. And remember, 90% approximately of people with SARS-CoV-2 infection have mild or no symptoms. So only a few end up really in the hospital. And if they do, they typically end up later in the disease course, typically already around at the start of week 2. when the virus is already on the decline. And this relates also to what Clara was just telling you about the mechanisms of disease. So in this area is essentially where most of the transmission is happening. So I told you 50% of transmission is pre-A or minimally symptomatic. Let's look at those patients who are completely asymptomatic. They are less likely to transmit, but less so because they have less virus in them, but more so because they have just less symptoms. If you don't sneeze around the virus all the time, then it's less so that you transmit. But the virus kinetics actually of symptomatic and asymptomatic patients are quite similar. And that's why it's so important also to control the pandemic, to test asymptomatic carriers as well. And we can detect them because the virus kinetics are similar, and the tests that we are doing, they detect the virus. So there's the same amount of virus in people who have no symptoms, or similar amount of virus than those who have symptoms. All right, so what are we testing for? This is typically the jargon there is, what are the use cases of testing when it comes to diagnostics research? But also it's quite simple. You can translate it into questions like, am I infected? Ideally, you want to know right away, yes or no. Sometimes you want to know it quickly, and then you might do a triage test. So you do a test that's imperfect, maybe not as specific or as sensitive, to then confirm it when you get a positive result. Was I infected? That was a question, I would say less so now, but more so in the beginning of the pandemic. How many people have been infected? Again, that's exposure in the past. That was very relevant for population level interventions and control. How many people are currently infected? Remember, in the beginning, we had no idea of whether the disease was largely asymptomatic or not. We had no idea of the numbers of people infected in the population, because we didn't widely test. We didn't have a lot of surveillance testing. So only when we had scenarios like in the Diamond Princess cruise ship in the beginning did we learn to understand how much asymptomatic infection is there. But generally, you would do that with population level surveillance. And lastly, oftentimes you will ask today, am I immune? And that's a very difficult question to answer with diagnostic testing. So in summary, like one can say, one size does not fit all. There are so many diagnostic questions or testing questions that you want to address, and you can already see from those different use cases that there are different tests needed. Generally, you can divide up population health and personal health. What is the difference? So personal health, it is you coming with symptoms into a testing site or a hospital, wanting to know whether you are infected. And then you want a very sensitive test that quickly identifies those that have COVID infected for two purposes. First of all, also for taking good care of you. And we now have some options, as Clara highlighted. But also to isolate you, because in a hospital setting, you have a lot of vulnerable patients around who are immunocompromised and so forth. So you want to make sure that you keep those COVID patients apart so that they don't spread the COVID in the hospital. Then you have the population health questions, and that is more about surveillance, as I just outlined, and screening. And screening, there might be different questions. There might be the questions of, I would like to come into this venue, maybe a restaurant, maybe a football stadium, maybe a hospital to visit my loved ones. And there's the questions of, or a school, actually. And there's the question of public health, where you want to understand on a population level how many patients are actually currently infected. So here, especially for entrance screening, you want obviously a quick test, right? Because it doesn't matter if you get the PCR 2-3 days later, football is over, sorry. And for public health, you might be able to have some flexibility, because you don't really need to know the result right away, because it doesn't have a consequence on the individual person at that time point. So dependent on what you're trying to do, the characteristics of the testing might actually be quite different. So what do we have available? The one that you will know best, I would probably, is the PCR test. PCR is the gold standard of testing, meaning it's the best test that we have, the one that most likely is able to detect the disease. That being said, there are also caveats. No test is perfect. But it is very sensitive. It's highly specific. Sensitivity might vary a little bit. I had shown you that the viral load goes down in the second week. Most of the time, people are still PCR positive, but there are rare instances where we find it, where we have a hard time finding the virus. Also, it might differ from how much virus you have in you, how much you were exposed to, the mode of infection. One says that in virology. And then it might also depend on the variability in the sampling method. Remember, initially, we had to go all the way back. I called it brain biopsies. It wasn't a brain biopsy. We stopped just before the brain, on the barrier, the bone there in the nasopharyngeal space. But if you did it yourself, you know, it feels like a brain biopsy. So that was uncomfortable, and many people didn't do it correctly. And so that might affect the performance of the test. PCR is just one. There are similar tests that perform similarly well. I'm mentioning here, I won't go into details on that. You might also know the antigen rapid tests. Here in Germany, you might know them because you can get them at any discounter across the street. Globally, they are not as commonly used and available as in Germany, actually, but they have played a critical role in the control of this pandemic as well. And this was, although initially back in March last year, we weren't sure whether this would be working well. But nowadays we have a good understanding of if they work well, what it takes to work well, how we can trust them, and how we have to be careful using them. So there are over 500 tests now commercially available. And there are 2 systematic reviews and meta-analyses, one from Cochrane, one from us, that shows that there's variable sensitivity between 40 to 85%, and there's variable specificity between 95 to 99.9%. This sounds less wide of a range, but in fact, this is quite a wide range because specificity very much affected by the pretest probability, so high the prevalence is in the population that you're testing. And in fact, when you test someone with a prevalence of about 2% in the population and have a test that's 95% specific, you get a lot more false positives than you get true positives. But these tests come in different shades of gray. Most of them are these so-called lateral flow tests that are very simple, instrument-free, can be read out within about 30 minutes or less. Some have a reader, which obviously has advantages because it also can transmit results and has a bit more of a sensitive reading mechanism, especially if, for example, immunofluorescence is used. So how good are these tests? This is my study team here. After we enrolled the first 1,000 patients, we ended up actually enrolling over 10,000 in the study in collaboration with FIND, the Charité in Berlin, colleagues in Liverpool, Brazil, India, South Africa. So this was a very successful study that led to a lot of useful data, both for regulators, decision makers around the world, WHO here in Germany and elsewhere, and also for people to decide better on which test they should be buying in the supermarket. In summary, the performance of antigen tests is, for good antigen tests in terms of sensitivity, around 85% sensitivity or 80% sensitivity. However, if you really test in that first week, you get a higher sensitivity. You get about 90–95%. And if this is in comparison to this PCR, which I told you is the gold standard. But the thing is, PCR also detects dead virus. And if you compare the tests actually to culturable virus, which this is also debatable, but one can say more likely to be actually the relevant virus to detect, because if it's viable and culturable, it's likely to cause disease, versus if it's mostly dead, but still detected by PCR in the second week or beyond that, it's unlikely to contribute to transmission. So based on that, we can say the sensitivity is high and can detect the transmissible virus. But we have to be careful, because when tested at any point of infection, then it might be, in comparison to a PCR, only 40 to 50% sensitive. And this also relates to the fact that the PCR is more sensitive, but also it detects non-viable virus. So what that exactly means, we don't know yet. But as I told you before, the antigen tests detect most of the transmissible virus, but you can see, if you look at the PCR positivity, you have a gap here, mostly before people develop symptoms, and you have a gap here where the antigen test is negative, PCR is positive, but here it might be a lot of dead virus as well, so it might be not important anymore to actually detect it when it comes to preventing transmissions. And this green line I put in here, it's exemplary, but this is about the culturable virus, and it actually should be more tilted like this. So this is culturable viable virus, and this probably still, but this probably not, roughly speaking. So what we can say is that with the antigen tests, we are likely to detect most virus when it is most relevant for transmissions, but we do have an important gap early in the disease. And this means that negative antigen test is not a reason to take off all masks and have a party. You still need to be careful, and especially when you interact with people who have a high risk of disease. We've heard a lot about variants of concerns, VOCs. We have heard a lot about vaccination, but how do they affect the performance of these tests? We know that most of the mutations of these variants of concern are in the spike protein. But fact is that the antigen tests, most of them detect the nucleocapsid protein, and most of the PCR tests detect a combination of both. And thus one can say for antigen tests that these antigen tests are not affected by VOCs. This is also now confirmed by data on these tests. But it has to be validated for every new VOC. How does vaccination affect the performance? We know that vaccinated people do get high viral loads, but it typically comes a little slower, and it comes a little lower. So we have a little less virus that turns up a little later, and it typically also falls more rapidly. So the kinetics, if we go back to this here, it's typically more like a curve like this. Should have painted it in here, but this is what we can tell from studies mostly from England, and what it does tell us that we are likely to detect the disease also, or the virus also, in people who have been vaccinated, but with a little less sensitivity because they have lower viral loads. That being said, the ones that we care about, the high viral loads, the early high viral loads that are most responsible for transmissions, so those we detect. So we said, like, antigen tests or PCR, we can use them in combination as well. I had spoken about a triage algorithm beforehand already. This is very much dependent on what scenario you're looking at. If you want to have a rapid test result to isolate people, or you don't have availability of PCR, then obviously your antigen test is good. But if you are in a hospital, for example, then you wouldn't want to rely on an antigen test, because you know that these the early rise you will miss, or you wouldn't want to rely on it and drop all other control measures. You want to make sure that people wear masks and keep distance. Fact is, that for many countries in the global south, the antigen tests were the only possibility, simply because there is very little PCR infrastructure, electricity needed for PCR, skills needed for PCR, and we'll get to that a little bit more. How can testing be scaled? Early on, we talked about the so-called brain biopsy, the nasopharyngeal testing, which is quite cumbersome. We showed both for PCR as well as for antigen tests, actually, that that nasal sampling is mostly equivalent to nasopharyngeal testing. And this is a systematic review and meta-analysis that we did half a year ago for PCR, and we did for self-testing with antigen tests a dedicated study where we did paired sampling and showed this, and this has now been confirmed by others as well. So most of the tests now are actually nasal testing. Caveat is that for PCR tests, you can also do saliva testing, mouth testing. For antigen tests, I haven't seen good data that this works, because the proteases, the enzymes in the mouth, do destroy the protein, and therefore your antigen tests work less well. Another aspect that's very useful, especially if you have stable cohorts, meaning cohorts that repeatedly meet themselves or mingle amongst each other, such as school children or workers, you can do pool testing with PCR, because there you can simply mix all of the sample together and test it in one. And this was actually a group in Cologne spearheaded this. Very useful for school testing with minimal reduction in sensitivity, and it enables large-scale screening and surveillance programs. If you do not have to have the rapid turnaround, and that's why I'm saying it needs to be in stable cohorts and repeatedly tested, because this is typically where you don't need a rapid turnaround. But even with the pool testing now, they have largely end of the day or next day results. Good. Tests of exposure, we have antibody tests, and they have gotten quite a bit better since the beginning of the pandemic, but still there's a lot of bad tests out there, similar as for antigen tests, by the way. You really need to be careful looking into what to trust in and what to buy. Especially the point of care tests, antibody tests have not been performing well. And we still do have cross-reactivity in these tests that hasn't changed. So we have a reduction in specificity depending on the tests. Important for tests in general, but specifically for these antibody tests, I just wanted to highlight it, is what I said in the beginning already. There is no perfect test. You can have true positives, you can have false positives, true negatives, and false negatives. And it's very important to consider your pretest probability. As doctors, we do that every day. We look at you as a patient, we see those symptoms, we decide these and these tests are most appropriate. And we don't just want to send off a slew of tests, because tests can be false positive, and then it goes down a rabbit chase, and at the end we find it was the test, there's no problem with the patient. And the same is true especially with these antibody tests, but generally this pertains to tests at large. So if you have a 5% incidence in the population, and if you then have a negative test, you are negative. But frankly, if you're positive, you might as well have flipped a coin, because with a low specificity of the test, and in this case, we're talking 95% specificity, you have a 50% chance that it's a false positive test. In contrast, if you have a higher cumulative incidence, and this is much more what we are dealing with now, so those antibody tests are not better than they were, but their test results are more reliable, because now if you're negative, you're still likely negative, but if you're positive, you also likely had it. Important is that if you test antibodies now, if you're vaccinated, you get antibodies to the spike protein. If you have been infected, you get antibodies to the spike protein and the nucleocapsid. So you want to differentiate between the two. And if you take another scenario where you have, let's say, 70% cumulative incidence, then if you're negative, you could still have had it, because then your sensitivity weighs in more. And for the positivity, the specificity still applies. So a positive test, you very likely have had it. So that, just as a side note, think about tests in the context of the pretest probability, because it matters a lot for how you are interpreting your results. But what are we testing with antibodies? Are they really a marker of immunity? We don't know, really, at this point. We can say that if you have antibodies, reinfection most likely results in less symptoms and less viral replication in people, and thus less transmission. But on the one hand, antibody response is only short to medium term. It declines, and Clara showed that as well, over time. And the question is, with that declining antibody response, does our protection, our immunity decline? And that's probably not the case, as we know now from the studies from the vaccines, also with the new virus variants. It looks like the more important aspect is the T-cell response that persists for longer and that prevents severe disease. And this T-cell response, we are not measuring with these antibodies. You can measure T-cell response, but unfortunately, those are typically research lab-based tests, so that they are not widely available. And the long-lived memory T-cell response appears to be associated with symptoms. So, so if you had disease from a SARS-CoV-2 infection, we're not talking about vaccination, just infection, then you likely have that good T-cell response that will protect you in the future. But how does it stand when you have had asymptomatic disease or minimal symptoms? We don't yet know whether those people are truly also protected going forward and have that T-cell response. And this is simply because most of the studies done only capture the ones that are symptomatic and follow them. So we don't have a good understanding of the long-lived T-cell memory response on asymptomatic people. So this is in summary to say your antibodies are good. They're an important measure to see whether you have had a response to a vaccine or the disease, but only really shortly after the vaccination and or the disease. They will fade over time, and they are not most likely a marker of your protection from the disease, severe disease going forward. So now we learned a lot about tests, about use cases, but like who and when do we actually test? I already said a little bit about these things. I'll go through this quickly, but essentially when you're symptomatic, ideally you would want a PCR test, but an antigen test gives you a result more quickly. And the PCR test is important when you are very sick and go into the hospital, because then you would want to have the best test both for you and for the protection of others. Now that we have a lot of virus circulating, for example, right now in Germany, it has to be also considered that sometimes someone comes with symptoms and they are coincidental positive. So you might have someone with a heart attack who had asymptomatic COVID, to simplify it. And that is something that you always need to consider, and has certainly resulted in problems for people because we overlooked other diseases. And obviously a negative test is possible as well, but not as likely, especially with a PCR test. For contacts of confirmed cases or healthy high-risk groups, again, you want to do a PCR or an antigen test. A negative test result makes you unlikely to be infected, but it could still be in the incubation period, so beware. Surveillance, there you want to sample a population independent of symptoms, and you can do that with PCR or antigen tests, depending on the prevalence. You can interpret that. Antibody tests can also be used, but they only tell you about the proportion of population exposed. I already told you about the imperfect performance, and therefore it needs to be considered, the relevance needs to be considered. But if you test people sequentially, or if you consider the limitations of the test, you can extrapolate from that. Screening, so here, this is mostly asymptomatic patients or minimally symptomatic patients. If you test here with an antigen test, infection would be unlikely. If the pretest probability is low, you would want to test with a PCR test to be absolutely certain. But large-scale programs with screening are really only possible with pooling. And you differentiate, as I said, along the way from changing in stable populations, the stable population, school, workplace, there you could do pooled PCR or antigen tests. Changing populations, like for entry screening, you really want a rapid turnaround time. And that's why antigen tests might be better. And this is all to say, not one size does not fit all, and we to understand the tests, what they can do, how they are limited in order to apply the right ones at the right time. How do we apply them as a strategy? Sorry, I misspelled strategy up here. So this is just a suggestion or like a possibility. Obviously, there are very different shades of gray, but essentially you want to diagnose and trace to contain. This is where you would want to have antigen or PCR tests. Then you would want to have your surveillance studies so that you know where your level of infection is. And for example, right now in Germany, we do a fifth of the tests than the UK. So we don't really know how many cases we have in the population. Ideally, you would want to have random sets of the population regularly tested to see where your population-wide infection is lying, so that you can institute population-wide measures. And then you want to model to predict. For that, you also need to know how many people have been infected, how many people have been immunized. And that's where the seroprevalence, so the antibody tests come in, but also admissions, mortality data, and all of that, so that you can do specific measures. And this is how these tests play together and how they can be used in a comprehensive strategy. And this is just the same thing said again. And how do we ensure people test or get tested? Now we are getting more into the public health part of things. Communication, communication, communication. That's all we really need, or not all, but this is a critical aspect of what we have to do. And I think we have failed in different countries, different and variable ways to really use testing to the extent that it could be used. Important is that the communication around tests is easy to understand, it's accessible, and also it's in your face. So that you understand what the benefits, but also what the limitations are. We need to ensure that different parts of the population are really addressed. And this is a little comic from the Austrian government that I liked, because it very much also, my son very much liked that, looking at it. It was like, testing is powerful. I can protect myself, I can protect others. This is what I want to do. I want to be a superhero. This is something that speaks to kids. And then you want to make sure that you address people in different languages. We have a large migrant population here in our clinical part of things. And fact is that many people are unfortunately not vaccinated or regularly tested. Also because it's harder for them to access information, to understand the information if it's only conveyed in one language or in very elaborate language. That's the other problem. And as I said, it needs to be in the places that people frequent. So it needs to be in people's faces. Then we need to think about incentives, nudging. It doesn't need to be a high reward, but it needs to be a little bit. It could be a free glass of beer. It could be a free day of vacation if you regularly test yourself, something like that. The same applies obviously to vaccination and access benefits. Like if I test, I can get in. If I vaccinate, I can get in. These are things that can be applied and can be applied broadly, but haven't been done. And affordable tests is another aspect for every country around the world, no matter how resource limited or rich it is. Because if you don't capture the people who don't consider a test affordable, then you don't capture large parts of the population. Fact is, a test for resource limited settings needs to be rapid, needs to be easy to use and not require instrumentation, be easy to transport, and ideally also needs to be rapid, because people often are much more mobile because they need to travel long to a clinic or need to go back again to do their work or care for their loved ones. And it's also very important that it recognizes transmission relevant disease. And all of this, as you can tell from what I told you before, applies to antigen tests, but not to PCR tests. And haven't been able to actually reach people with tests? Somewhat. I would say we didn't do well, and we did, unfortunately, actually even worse than we're currently doing with vaccines. And that's I mean, it's really a shame, and it's really a failure of the global community. If you look at vaccine coverage, and this is a courtesy from FIND that I have this slide, the vast majority of the population outside of the high-income countries is without access to vaccines. So this is the number of times doses given in high-income countries versus low-income countries. If we look at testing rates, this is the number of times tested in high-income countries versus low-income countries. So this is a huge inequity. And this is a huge inequity that doesn't only result in individual hardship, but lives lost and economic cost and huge implications globally. So there has been a lot of work done by international agencies in form of the ACT Accelerator, for example, and others, to try to get testing more accessible to patients or people in limited resource settings. And this is something that FIND has been instrumental in, and I just highlighted some of the achievements. This is from the quarterly report of July, where they report 10 affordable tests have been developed. There has been manufacturing capacity created for diagnostic tests in the Senegal, and I forget where in the other country. There has been a lot of investments made for countries to buy the tests at affordable prices. There's been knowledge sharing, healthcare worker training, and so forth. Have the tests reached the people? Have they helped to control the pandemic? I mean, the seroprevalence in limited resource settings shows that the contribution has probably been minimal because it came late and because it came, it's insufficient. And when we were struggling to get vaccines, masks here, you cannot imagine what it meant in being a doctor in limited resource setting. So this is good and nice, but we can do much better, and we have to do much better in the future. And obviously testing is just one component. We need to do a lot of other things, both on the level of personal responsibilities and shared responsibilities. And we do need to do them equitable. And there, I think we have not done so well. I wanted to quickly talk about how COVID has affected other global health problems. And I chose TB as an example because a lot of my work is on TB, and it is the infectious disease that, aside from the last 2 years when it was COVID, actually is killing the most people globally every year. And COVID and TB are actually very similar in their early presentation. And given that early on there was a lot of fear and stigmatization around COVID, we also saw 75% reductions in presentations to TB care. And we saw that people who had TB also, when they had COVID, had more severe disease. But we also saw opportunities. We were able to scale up COVID testing much more quickly, but on the backdrop of using TB platforms for PCR, like these are just two mentioned that are point of care or near patient PCR platforms, but also on the centralized platforms. And I already alluded to it. We lost a lot of very good healthcare workers, very dedicated healthcare workers to COVID, excellent researchers in endemic settings, and this is going to affect us for years to come. But talking about 75% reductions in people presenting to care, what does that mean? It doesn't mean that there's less TB, but it means that people are just presenting later, that they are transmitting more. And we have seen already in this WHO report this year, and we'll see even more so in the future, that we have lost efforts in TB and are set back by about 8 years when it comes to incidence, and about 5 years when it comes to deaths, in terms of what we have achieved on TB control. And this is not just TB. We've also seen HIV, malaria, people not getting bed nets, people not coming for their vaccine, for their medications, getting rebound in viral load with HIV. We have seen a lot of problems in vaccination campaigns being suspended, which has huge implications for the children going forward. We will be seeing a lot more deaths from measles and other vaccine preventable diseases going forward. But we can also learn a lot from COVID. We can increase health. We can use the increased focus on health systems. There have been, for example, in Africa, 5,000 platforms of a test distributed that could be used now for tuberculosis or HIV. We've also learned a lot from COVID in terms of resource material management, supply chain management, innovation in diagnostics and vaccines. And this needs to be now translated into impact for other diseases. TB is just one example. So this was a little bit of a whirlwind of a lot of information, but I hope, coming back to what I set out to answer for you, is there a best test? There are lots of good tests and they need to be applied purposefully. The best test for screening programs is probably the antigen test, but they need to be chosen carefully because there's lots of variability. Can antigen tests be done by anyone who is not skilled? We have shown that, yes, there's very good performance even in the hands of non-skilled workers. Antibody tests don't tell you necessarily if you're immune. It's probably more likely the T-cell immunity that is hard to test for. Testing is a critical aspect of public health disease control, but it's only just one aspect. It needs to come together with other control measures. And we need to consider how SARS-CoV-2 has affected other disease programs. And we need to, as a community of global health researchers, ensure that we counteract those, this impact on the one hand by working even harder and by leveraging also some of the achievements that have been made with SARS-CoV-2. Thank you very much. And obviously, all of our work is not just the work of me and my team here, but many others. And yeah, thanks, and look forward to the questions of the audience here.
Thank you, Claudia. Actually, I didn't dare to push you further. It was so exciting, and we have really seen from the development of tests to the clinical aspects, to the public health aspects, and the global health aspects. I'm afraid that we, however, have lost the time for questions. We need to give the audience a little bit of a break. I think your last summary slide was of extreme importance. The main message is really clear that we have a variety of tests, but we need to use them wisely and correctly. And what really also, after our discussion yesterday about equity, was a worthwhile remembering point, that even the access to testing is so inequitable around the world that we need to have that in mind and really improve on that. Some of the messages, though, I felt, if I look at the German situation, that we are very poor in performing population-based surveillance studies. We are trying very hard, but it's we learned already a lot what we can improve for further pandemic preparedness for a setting like in Germany. Maybe one question I cannot avoid to ask you, well, as a strategy. Now, you said there is nudging, you suggested that, but we have a strategy in Germany now to make people pay for tests. And you said how important testing is. So it's not nudging, it's more punishment of people who are not yet vaccinated, and they should now, if they want to get access in this famous 3G rule, pay for the test. What's your take on that?
Yeah, thank you, Florian. And I apologize that the presentation was in presenter screen all along. I didn't see the chat, and that's why I had asked in the beginning. I wish someone had just called out. So apologies for that. But I think the slides will be shared. So if you want to take a look at them, you aren't able to see some of it, you'll have access to them later. To your question, I mean, I think right now the impetus to do the make the tests paid for is to nudge people to get vaccinated, because that's how they can get around it. Is it the right way? I don't think so, because the people, I think we're failing on communication, making vaccinations easily accessible to people. And that's what we should be working on. I have worked for last weeks trying to get vaccines into our clinic here, because we see so many people from a migrant population who are not yet vaccinated. It's impossible, the bureaucracy. And I think, unfortunately, I think the testing at this point, it doesn't make much of a difference. What we have failed to do with testing is to normalize it, to make it something like teeth brushing that we do on a regular basis, and to reach with the testing also the people who are marginalized in the population. I don't think we'll be reaching a lot extra by making them affordable now. Because it's lacking on the other sides. That being said, yes, absolutely. I think tests need to be affordable. But I have a little bit of a pessimistic view that I think we failed on many other fronts. So that certainly like the so-called Bürger tests in Germany, I don't think can be justified from an economic point of view at this point. But I think making tests affordable when it matters is still something that should be done.
Yeah, thank you. It's again a differentiated view, like Oliver from Munich said, that the cost per detected case is really really high in our current strategy. So. Yeah, I think because we planned already to start the next session now, we have to stop here, but not without saying thank you. You are invited to listen to the panel discussion, of course, this afternoon. And otherwise, I know that you are sitting in the clinic and you had patients before. So really, really a big thank you for making time to be with us.